Hi, I'm David Hayes, Chief Medical Officer for BIOTRONIK, and I want to talk today about loop recorders as I think about my early experience with them and how they are today. The first time I was introduced to a loop recorder was very early in their availability. My institution was not an early adopter, and there were initially some questions about reimbursement, so it was probably not for a year or two later before I used one. If asked if I was initially receptive to the ILR concept, I would say that for the patient who was having infrequent but significant symptoms, or the patient who was struggling with an event monitor, an external event monitor, which we were using very frequently, the implantable option seemed reasonable. So overall, I was receptive to the ILR conceptually, and I was receptive to the procedure as well. The first time I had the opportunity to implant a loop recorder, we treated it like any other implant, pacemaker, defibrillator. We were so concerned about a potential infection and avoiding complications that we imposed all the same processes and procedures that we would for any implant. We were also giving patients some IV sedation in most cases, those early cases, because the devices were larger. We didn't want to cause any discomfort when we created the space or the pocket for the device. As they got smaller, we obviously went to local anesthesia only. I also remember on those early implants that we did the required pre-implant testing or mapping to determine where we should place the device to get the best ECG recording. That is, would it be parallel up and down to the sternum? Was it angled in a certain direction? I don't recall really any surprises with the early implants. Despite the larger size and the precautions we took and the mapping required, they were still relatively easy to place. Well, I can't recall specific individuals that got those early ILRs. I do remember being impressed with some of the early cases of the ability to make a diagnosis or rule out a diagnosis, which was often equally important clinically, when we hadn't been able to make a diagnosis with other diagnostic modalities. If I think about the contrast between the first loop recorders that I implanted and the contemporary injectable cardiac monitors like the BioMonitor 3M, there are lots of key differences. The most obvious is the size and being able to get more information and more storage in a significantly smaller footprint. The smaller size allows the current devices to truly be injected, and the injector, for example, for the BM3 is really easy to operate. The apparatus doesn't need to be flipped over like was necessary in some of the ILRs, and it comes preloaded, and the time measured to place the device after the incision was made was on average only 39 seconds. Another difference with the contemporary BM3 in contrast to the early ILRs, and really all other ILRs even today, is the longer antenna, and that's designed for the specific reason of having a superior signal. The bigger the antenna, the bigger the signal correlates with less noise with fewer interruptions or artifact, and lower number of false episodes of atrial fibrillation detected. The longevity of the ILRs has increased dramatically. The current BioMonitor 3 has a longevity of 5.5 years, whereas the early devices had stated longevity in the range of 14 to 18 months. I already mentioned that there was more storage and more information shared with the clinician. With the early devices, we were only getting the ECG with a limited number of events stored, and in the very first ILRs, if memory serves me, the only events saved were those that were triggered by the patient. In the BioMonitor 3, there's up to 96 minutes of stored information with a first in, first out intelligent memory management system, which compared with the early ILRs is significantly more. In the BioMonitor 3 and 3M, we get the ECG, but we also get trends for resting heart rate, mean heart rate, activity levels, and there are other physiologic parameters that are currently being collected or capable of being collected. Remote monitoring was not available on the early ILRs, although for BIOTRONIK, even the first BioMonitor was part of the home monitoring system, so there were daily transmissions from the very beginning of that experience. With the BioMonitor 3, again in the BioConcept study, it demonstrated that daily transmissions were successful 98% of the time. One of the issues with ILRs from the early days was the difficulty distinguishing true episodes of atrial fibrillation from false positive episodes. That has improved markedly. And with the Biomonitor 3 device, atrial fibrillation episode, the positive predictive value was 98.5%, and with the new rhythm check feature on Biomonitor 3M, false positive episodes of atrial fibrillation due to ectopic beats were further reduced by 72%. Patient selection has changed to some degree. Again, I've always considered the primary indication to be the patient with unexplained symptoms, syncope, near syncope, palpitations that were infrequently and unpredictable. But my threshold for using an ILR has become lower with the advent of easier implant or injection technique, better reimbursement, and the fact that ILR indications are now part of the published guidelines. I really believe that the future for ICMs is pretty much limitless. I envision further miniaturization, more physiologic parameters, for example, temperature, maybe oxygen saturation, more patient interaction through apps, likely an improved alert system for patients that could allow them to take specific precautions, and possibly application of artificial intelligence to predict future events. So, for example, with trending of episodes of true atrial fibrillation based on the pattern, the length, etc., the device could begin to predict future course of atrial fibrillation, which could allow earlier intervention. When I first heard about implantable loop recorders, now injectable cardiac monitors, I never thought they would become as small or as smart as they are now. But clearly, like every other technology curve we've seen with cardiac implantable electronic devices, we're probably just at an inflection point, and we'll continue to see rapid evolution and expansion of monitored parameters in implantable loop recorders.